45-year-old female being evaluated by her primary care PA for a routine physical. The patient is found to have a diastolic murmur and auscultation. Which of the following could be present? What are your thoughts? B, bravo, right. Okay, so when you're looking at it, you should see and recognize all these other ones are systolic murmurs, and the only one that's diastolic is mitral stenosis. Because again, mitral valve should be open during diastole, right? So if it's supposed to be open, then it has to be a stenotic murmur. So mitral regurg is systolic, pulmonic stenosis is a systolic, mitral valve prolapse is systolic, and then of course aortic stenosis is systolic as well. Our next one is a 25-year-old female, history of Marfan's, has been followed by her primary care team for a known heart murmur. On auscultation today, she is found to have a mid-systolic click that precedes a flow murmur. With Valsalva, the click occurs earlier in systole and lasts longer. What is the most likely valvular disorder to explain this auscultatory finding? What are your thoughts? Delta? Yeah. So mitral valve prolapse, kind of some things in the vignette that might suggest it is, okay, you got a connective tissue disease, but so you have a little more elasticity to those chordae tendineae. So you're going to have that excessive movement of the valve back into the left atria. But then remember, we talked about how with the dynamic maneuvers with mitral valve prolapse, when you adjust that preload, you can distort when that murmur is going to occur. So if I reduce my venous return, I reduce my preload, I now don't have a larger ventricular cavity, so I have less strain counter resistance on those chordae. So that means that that murmur, or that click, that billowing is going to occur earlier in systole. When I do things to increase preload and increase venous return, I now have extra tension placed on those chordae, so it delays that excessive movement of the mitral valve. Okay, so the dynamic maneuvers have this kind of unique finding, and it all comes down to preload. And then the last question we have is a 15-year-old male presents to his primary care PA for recurrent fevers, joint aches, and a new rash. With further history, he reports that he had a severe sore throat 2 weeks ago with difficulty swallowing, which resolved after a few days with ibuprofen and acetaminophen. On auscultation, he's found to have a holosystolic murmur that radiates to the left axilla. Which criteria could be applied to this patient to help with diagnosis? Yeah. So Jones criteria, so echo is the correct answer on this one. So good. Okay. All right. So let's move on and let's start talking about the aortic valve now. And the aortic valve is important because in the United States, aortic stenosis is the most common valvular disease you're going to encounter. Okay? So in the United States, this is the most common. Remember, globally, we said mitral because of rheumatic fever, rheumatic heart disease prevalence, right? But in the United States and in industrialized nations like in Europe, aortic stenosis is the most common valvular disease you're going to encounter. And the most common cause of this is a congenital bicuspid valve. Bi meaning two. So instead of having kind of this Y-shaped opening appearance of the valve where you have those three leaflets meeting together, you now only have two leaflets because this is fused right here. So now that increases shear force and stress and everything like that because that surface area that's being impacted because of that high pressure movement of blood from the ventricle and out is going to add a lot more shear force because that surface area is diminished. So you have a more focused pressure distribution, okay? And that's present in about 1 to 2% of the population that we have. So maybe one of you in this room has this condition. Now, outside of something that you're born with, the other common causes in the US is this degenerative calcified disease. Kind of think of it as the atherosclerosis of the aortic valve. So the same risk factors that go along with making somebody at risk for atherosclerosis also go into developing this condition, okay? And usually these are patients that present much later in life because they need to, one, have this condition to induce that atherosclerotic kind of change long enough to disrupt the normal valve itself. And then the third most common thing is rheumatic heart disease, but globally, that's the most common cause of this. But in the US and Europe, third most common cause of aortic stenosis. Now you might be wondering, why do we see the physiologic changes associated with aortic stenosis? And it comes down to, typically in a normal functioning heart, very little pressure should be necessary just to open that valve, okay? So what that means is, so let's say the diastolic pressure on this side of the aorta is 60, okay? That means I need to generate 61 millimeters of mercury in the ventricle to open that valve, okay? Because very little resistance is there in that opening. I just need to exceed that diastolic pressure by 1 just to get that aortic valve open. But now, if you have a stenotic valve, and now, let's say you need 20 millimeters of mercury just to open that. If I still have 60 here, sorry, I'm trying to do this with this little mouse thingy. That means I need to now generate 81 millimeters of mercury in order to open that valve. So now I'm having to exert a much higher pressure. And as that diseased valve gets worse, I'm going to require more and more pressure just to open it and get that blood flowing out of the ventricle and into the aorta. So that means, ultimately, I'm going to have to work harder, I'm going to have to squeeze harder, I'm going to have to squeeze longer, which means I need more oxygen. And if I don't get that oxygen, then that means I'm going to have ischemia, and that could lead to heart attacks, right? So that's one of the pathophysiologic changes that we see here. Now the other thing that we see is the supply gets diminished. So now on one side of this pathophysiologic changes, I'm increasing my demand, but on the other side of it, I'm decreasing my supply. So now that delta of supply and demand gets even worse, which means I'm more prone for myocardial ischemia, which then also then leads to cell death, which means function deteriorates. Okay, so you can see kind of how this thing works and how it alters that supply and demand, leading to significant pathology, even cardiac cell death. Okay? With patients with aortic stenosis, your body's going to be able to tolerate this condition for a while. So there is a prolonged asymptomatic period with this. Okay? But eventually, as the condition gets worse, you're going to be limiting that ejection fraction or the amount of blood that gets ejected out, and now you're going to start to have symptoms. But the symptoms are related to a cardiac output problem, which means exertional symptoms. So I'm going to have exertional lightheadedness, dizziness. I'm going to have exertional chest pain. I'm going to have dyspnea on exertion, so shortness of breath with exertion. And it's all related to that cardiac output dropping down so that I cannot support function. Okay. Now, unfortunately, a byproduct of this also is that excessive pressure and volume that is in the left ventricle will then start to impact the left atria, which then can lead to heart failure symptoms as well. So pulmonary congestion. If it affects the right side of the heart, then you're talking about JVD, peripheral edema, gut edema, all those kinds of things. So as a byproduct of that reduced cardiac output, things back up upstream and lead to heart failure. But when we look at somebody and we suspect maybe something's going on, what might we hear on what would we see on our physical exam? Typically, the murmur that you're going to get is this crescendo, decrescendo pattern in the systolic phase, best heard in the aortic auscultation site, so the right upper sternal border, right? Now, you may be wondering, well, why is it a crescendo, decrescendo pattern? And the answer to that is, think about what's going on with the pressure of that flow of blood going across that valve. When you, sorry, I'm just trying to hang up that. So when you are squeezing the ventricle, that pressure is increasing, right? So that as you increase that pressure, you're going to increase that turbulent flow. So I'm squeezing, 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 higher pressure, higher pressure, higher pressure, more turbulent flow, more turbulent flow. I reach that peak, and then things start to relax, and that flow starts to diminish. So as that pressure starts to drop, you start to get that declining turbulent flow, and that leads to the softening of the murmur, and that gives you that decrescendo pattern in aortic stenosis, okay? Some other things you might find is, well, one, that murmur radiates to the carotids. Think about that direction of that flow of blood that's causing that murmur is to go up to the peripheral arterial system, and the carotids is one of those first offshoots that you can actually hear that murmur. So you can actually hear the murmur by auscultating the carotids. Another thing that you might notice on your physical exam in somebody with aortic stenosis is this pulsus parvus intardus, weak and late. Okay? So what happens is you're auscultating, you hear the squeeze of the heart, you palpate like the carotid, and there's a delay in that reaching the carotid. You can feel the squeeze with like your PMI, but that pulse, the actual byproduct of left ventricular function and getting that blood circulating, you're going to have a delay in palpating that in the carotid because you're delaying that opening of the aortic valve to get that blood ejecting out of the left ventricle. And it also tends to be weaker because you don't have as much flow occurring out of that left ventricle with a diseased aortic valve. So pulsus parvus intardus, weak and late pulse. Okay. On your ancillary studies, what might you see? Well, you may start to see nothing initially, especially if it's not a severe case and the patient's asymptomatic. But as it gets worse, you may then start to notice left ventricular hypertrophy because I'm having to compensate to generate a much more powerful squeeze to get that blood out of the ventricle and into the systemic arterial system. Okay? So you may start to notice that. But the other thing you may start to notice is as that stress and that strain is applied to the heart, it starts to elicit arrhythmia. So things like AFib, you may start to notice with this condition, okay? Chest x-ray may be normal, may see some enlarged, like an enlarged left ventricle. The echo is going to be your test of choice because, one, you can actually visualize the functional movement of the valve. You'll be able to measure the surface area, which is going to be important in a couple of slides when we talk about severity. But you'll be able to measure the surface area of the aortic valve, and you're going to be able to determine how much blood is actually getting out of the left ventricle. Okay? So echo is going to be the test of choice and is the most important test for you to do in these patients. Now, some additional tests that you may need to do is if they have a congenital bicuspid valve, you may need to do a transesophageal echo because that bicuspid aortic valve carries increased risk for aortic dilation or aortic aneurysms and aortic dissections. So you want to look at the aortic root to make sure those things are not happening in addition to that congenital bicuspid valve. Okay. CT or MRI, that just is a surgical planning kind of thing. But one of the important things you can do is if on echo, their patient is diagnosed as severe aortic stenosis, and they say that they are not having any symptoms, you need to verify that they in fact are not having symptoms versus they just have changed their lifestyle to accommodate the symptoms, okay? What I mean by that is this takes years, right, for this to develop. And you have a triathlete who then starts to notice they're having problems with competing. So they start to decrease their activity. So maybe instead of being a triathlete, maybe they just do marathons and that's it. Okay, that's a decline in function, right? But still, better than most people. But then that marathon runner is like, man, marathons, I can't do it anymore. Now I'm gonna do 10Ks. Well, now 10Ks are getting hard. I'm gonna go to 5K. 5Ks are gonna get hard. I'm gonna do 1 miles. 1 mile running is hard. Maybe I'm just gonna walk a mile. Okay, those are maybe not true symptoms to the average population, but to that individual, they are making changes in their lifestyle because their condition is impacting their ability to function. Now that was an extreme example, but think of your 75-year-old grandparent who used to get up and walk around the house, clean the house up, do some gardening outside, but now they just feel like sitting on the couch and watching TV, watching The Price is Right, right? That is a change in function. They say I'm not having any symptoms, but in fact they actually changed their lifestyle because of the symptoms and how they were feeling. So we want to do exercise testing to make sure that they truly are asymptomatic with exertion or with a stress to make sure, because that's going to tailor how we treat it. And in like 2 slides I'm going to show you why is that important. Now this, when you diagnose somebody with aortic stenosis, you're going to have to do surveillance because this is a progressive disease. This is not something that's going to plateau and stop declining. It's going to continue to get worse. So you have to know how frequent you need to do echoes. I don't expect you to memorize this chart. The one thing I want to just highlight is to meet the definition of severe aortic stenosis, your surface area of your aortic valve is less than 1 centimeter. And you may be like, well, 1 centimeter, that's not so bad. Normal is 3 to 4. So you're talking about a fourth or a third of that surface area is present compared to normal. So, so severe just know that the valvular surface area is when that gets to less than 1 centimeter, okay? So how are we going to treat these? Well, there's really nothing that we can do to kind of slow the progression of this. There are things that we can do to change and alter the pathophysiology to take some of that stress off of the heart. One of those is hypertension, okay? If I can lower that diastolic blood pressure to lower the threshold that needs to be reached in order to open that valve, maybe I can restore some functional response to that left ventricle, right? So let me lower that afterload with things like ACE inhibitors. And it has the additional benefit of having that, it helps prevent that adverse cardiac remodeling. So it works a couple of different ways in order to help this condition. And this is a treatment algorithm, but it basically comes down to if patients having symptoms and they meet the definition of severe aortic stenosis, meaning that that aortic valve area is less than 1 centimeter, right? They are having symptoms, they're getting a valve replacement, okay? So symptoms and severe, automatically getting a aortic valve replacement, okay? And what does that look like? So it's actually something that we do that doesn't involve an open heart procedure. So it's a less invasive procedure. And it's called a transcatheter aortic valve replacement, or TAVR. And basically you can see there's a couple of different approaches that you can do this, where we thread wires into the heart and you have that new valve collapsed over a balloon, and you get it into position, and then you inflate the balloon, and it deploys this new valve that you see here on the right side of the screen. Basically, you're pushing that diseased valve out of the way, and now you have that new valve present. And these folks who undergo a TAVR, they will immediately improve function. I saw this in a patient when I was a medical student interviewing. I was doing a cardiothoracic surgery rotation. And we had a patient who was admitted. He could barely push himself out of bed and stand up without feeling short of breath, just because of how bad his symptoms were. As soon as we got him out of the OR and he recovered from the anesthesia, he was doing laps around the ward because he now had a cardiac output that could meet that exertional demand. Okay? So it was almost an instantaneous improvement in his function and his well-being after getting this procedure done. Now going back to the exercise testing, why is it important that we identify patients who say they're asymptomatic but with severe aortic stenosis? Why is it important that we identify that they in fact are asymptomatic? And the reason for it is once symptoms start to develop, that mortality or that prognosis starts to get worse, okay? So you can see if somebody starts to have anginal symptoms with exertion, they have less than 5 years to live. If they have syncope with exertion, less than 3. And if they have shortness of breath with exertion, less than 2 years. So you can imagine your elderly grandparent who now just watches TV on the couch, doesn't do anything around the house because that exertion causes potentially some of these symptoms. They go undiagnosed and not properly managed because they've adapted their lifestyle to their condition. You're not going to identify these people until maybe too late. Okay? So make sure you do that exercise test when somebody is severe aortic stenosis on echo, but they say they don't have any symptoms. Okay. So that was aortic stenosis. Any questions about that before we move on to aortic regurgitation? So remember what we talked about yesterday when we talked about mitral regurg. When you're talking about regurgitation valvular diseases, you have to assess whether this is a primary cause, meaning that the valve leaflets itself or the valve components are the problem, or is this a secondary problem where something outside of the valve is interfering with the normal function of that valve, okay? So that's primary versus secondary. And then the other thing we talked about that you have to consider with regurgitation valvular diseases is what's happening in the acute setting and what's happening in a chronic condition, okay? So this is no different in the aortic valve when you're talking about aortic regurgitation. And you can see here's a couple of examples of things that can cause chronic causes of aortic regurgitation, okay? And you have primary causes and you do have some secondary causes as well. But ultimately, what happens in this condition pathophysiologically is, and especially in chronic, is the heart is going to compensate for that extra volume, compensate for that extra pressure, and it's going to cause a left ventricular hypertrophy. So it can generate a more powerful squeeze. The ventricle squeezes, it sends that blood out, but because that valve doesn't have the integrity that it needs, a lot of that volume comes right back. So what ends up happening is you'll see this widened pulse pressure, and this is a hallmark finding in somebody with aortic regurgitation, chronic aortic regurgitation, where that systolic blood pressure may be 150, 160, but that diastolic pressure is 40, because that volume that should be maintaining that diastolic blood pressure is coming right back to the heart. Okay, so widened pulse pressure is hallmark of aortic regurgitation. And if you remember, widened pulse pressure is that difference between systolic and diastolic is greater than 40 millimeters of mercury, okay? Now in acute aortic regurgitation, things that can cause this is like infective endocarditis, where now those valve leaflets are not being allowed to close properly because of that vegetation, or maybe there was an erosion of the valve leaflet itself, so now there's a big hole in that leaflet so that blood can return. It could be from like an aortic dissection, where now you're tearing that valve leaflet, or maybe we were doing some kind of procedure like a left heart cath or something, and we damaged the valve. Okay, so there are some iatrogenic causes of this. But the pathophysiology to this is the ventricle doesn't have the time or the opportunity to compensate for that extra volume coming back and that extra pressure coming back. So the pressures are going to quickly increase in the left ventricle with all that blood volume coming back, which then leads to backing up in the left atria, increasing that pressure and that volume in the left atria, which then leads to that pressure being translated to the lungs, and now you're having pulmonary congestion. So that you get this acute decompensation because of this condition backing up and affecting the lungs. So you can see the difference in the pathophysiology of acute versus chronic, where chronic is more a forward flow problem, an exertional kind of problem, whereas in acute, you're getting more of that pulmonary complaints because all that pressure and volume is backing up into the lungs. And similar to what we saw with the aortic stenosis, with aortic regurgitation, we're seeing increased pressures, we're seeing increased volume, we're having to increase our workload, which is leading to an increase in my demand, leading to ischemia if that supply can't keep up. But on the other hand, remember, which phase of the cardiac cycle perfuses the coronary arteries? Diastole, right? If I cannot support a perfusing diastolic pressure, and oh, by the way, all that volume of blood that should be going to the coronary arteries is just coming right back to the left ventricle, you can see how that's going to impact that supply portion of that supply demand. And now that's going to lead to ischemia, infarcts, and further decline in the function of the left ventricle because of that supply-demand mismatch. So all of the pathophysiologic changes lead to a distortion of that supply-demand variables, leading to myocardial ischemia, reduced function, leading to left ventricular failure. So going back to what you're going to see in your patients, so if you have an acute onset aortic regurgitation, you're going to see that pulmonary edema, that pulmonary congestion. If it's chronic, the hallmark is that widened pulse pressure, okay? And then you start to have exertional kind of symptoms associated with that. During the break, I'm going to try to pull up some of these physical exam findings. The internet was just being weird when I was trying to get my computer working. So let me try to get these during the breakup and I'll show you. But these are some pretty significant physical exam findings that are associated with aortic regurg. I can't get them to work in lecture. I encourage you to click on these links. It's safe, I promise. It's just to YouTube. I'm not trying to give you a virus. But it's just, I would take the opportunity to look at some of these physical exam findings that you can see in your aortic regurgitation patients. Okay. So what are you going to see on physical? So aortic regurgitation, if you recall from the first block, the best place to hear aortic regurgitation murmurs is Throat point. Okay, so the left sternal border. Okay, and you're going to see this decrescendo pattern, and the reason for that is that pressure gradient between what's inside the ventricle and the aorta is going to be at its highest when that valve should close, right? So you're going to have a lot of blood returning down to the ventricle. Well, now that pressure starts to increase in that ventricle, so now that pressure gradient between aorta and ventricle starts to decline, and that starts to slow down that regurgitation, which then means that intensity, that how loud that murmur is going to start to diminish, and you just get this decrescendo pattern. Okay, so this is a diastolic decrescendo thing. Okay. Now, one other thing that you may appreciate on your physical exam is this Austin Flint murmur, which is best heard in the mitral valve auscultation site. And you may be wondering, well, why do we hear that? Well, the reason for the Austin Flint murmur is as that volume of blood is coming back from the aorta through that aortic valve, it runs into the anterior leaflet of the mitral valve. So now you're kind of having like a brick wall is being placed in front of that jet of blood coming back. And what's going to happen is that jet of blood is going to kind of start to close the mitral valve. So it's going to mimic a mitral stenosis type of murmur. Let's kind of think of it as there's now a resistance to opening that valve, or there's a resistance in that flow of blood from the left atria and into the left ventricle, okay? So you may have this abnormal finding present because that jet coming back from aortic regurgitation runs into that mitral valve and partially closes the anterior leaflet of it. Okay. Ancillary studies, what can you see? Well, EKG, you may start to see a left ventricular hypertrophy. If that's affecting the left atria, you may start to see left atrial enlargement as well. chest x-ray. Remember, the acute presentation of this is pulmonary congestion, so you may see that. In the chronic setting, you may just see an enlarged heart because those ventricle and that atria enlarge. Okay, so you may just see cardiomegaly, and that's it. Echo is going to be your test of choice for this condition because you can measure how much flow is coming back and then also some of the secondary effects from this aortic regurgitation. How do you treat it? Well, if surgery is not recommended, we're going to do things to reduce that afterload and try to encourage more blood to go forward. Okay. So if I have decreased systemic vascular resistance, more blood should continue through versus backing up and into the left ventricle. Beta blockers, on the other hand, this is if anybody needs a clinical inquiry topic, this might be a good one to look into. There's a controversy for it, okay? And the reason for this is we've talked about all the positive benefits of beta blockers on reducing the adverse cardiac remodeling, right? That improves mortality. That sounds like a good thing, right? But the problem then also with beta blockers in this condition is, what does it do to the heart rate? Slows it down, which means we increase our diastolic time, and this is a problem, this is a condition of diastole. So you're going to make the regurgitation worse because more time is spent in diastole versus systole by slowing that heart rate down. Okay? So this is one of those conditions where it's like beta blockers may not be the best thing to do for these patients, even though there's mortality benefit and all these other things that go along with beta blockers. We may make their condition worse by increasing that diastolic time. There are criteria to doing surgery, and that's important because this is a progressive disorder, okay, especially from the chronic standpoint. Acute, I mean, they're going to be immediately symptomatic, they're going to be immediately going back and getting surgery. But in the chronic setting, this is a progressive thing. You can go from being asymptomatic with aortic regurgitation to having severe symptoms within 10 years. Okay? And similar to aortic stenosis, if you start to develop symptoms related to it, your prognosis gets worse. So if I start to have chest pain, anginal symptoms, I have 4 years to live. If I start to have dyspnea or heart failure type of symptoms, I have less than 2 years to live without surgery to fix the condition, okay? So, so be careful about your symptomatics and the symptoms associated with this condition, because that can alter when you pull the trigger to do surgery in these patients, okay? That brings us to 50 after, so let's go ahead, take 10 minutes, we'll come back and finish up our other 2 cardiac valves.
Oh, dude, I was yeah. That's why I had it on there, and I was like, immediately, because it was like this. Yeah, I pictured it really bad. It's like the great with the marksmanship. I thought that was now roll it. Yeah, but it's I thought like if it's not me, then they're measuring the distance between the malleolars. It sounds like a bow running if your malleolars together. So I asked him about how they like, oh, okay, but then he's like, it's really and I switched serving.
But also, I mean, I guess I haven't seen how if they were told
It'll buff. What do you need? You need someone to come down there. That was like the what do you want? ABC News is talking. Dude, I spent extra time at the airport.
If I had not changed two answers, what else? I always have a external snapping. I had the external snapping. It's the internal snapping.
Oh, yeah. No.
I got some good chairs there. You gotta carry that. Well, calculate what you get for farm.
All right, let's get back to our seats. Yeah. Oh, wow. Service. All right. So in 15 minutes, we got through one heart valve. We got 2 more to go. I promise you it's not going to take 2 hours. Okay. And the reason for it is these next 2 valvular heart diseases are very infrequent, especially in the United States. So we don't spend too much time actually talking about these 2. Okay. So tricuspid stenosis. So again, tricuspid valve should be open during diastole and closed during systole. So that means that with tricuspid stenosis, this is a diastolic murmur. And what happens with tricuspid stenosis is all of this pressure and all of this volume problem that develops because of that resistance to opening the tricuspid valve translates to changes only to the right atria. The right ventricle is unaffected because it's not experiencing those pressure and those volume problems because it's going to squeeze whatever volume of blood actually gets to it. Okay, so it's not going to impact that. It's all right atria. Now the problem with it is this becomes a right ventricular outflow problem just simply because you don't have that preload in order to support the appropriate stroke volume, okay? And I'm going back to our dreaded jugular venous pulsation wave. One of the things that's unique that you're going to see on your jugular venous pulsation waves with tricuspid stenosis is you're going to see this giant A wave. And going back, let's remember, the A wave is that atrial kick part, right? So I have to generate a much higher pressure in order to open that tricuspid valve. So I'm squeezing against a closed tricuspid valve. That's going to rapidly increase my pressure. So I'm going to see that A wave get larger than normal. Okay. What are you going to see or hear on physical exam? This is a tricuspid valve, so you're going to be listening to the tricuspid auscultation site. We also said that this is a diastolic murmur, so this is going to be a diastolic murmur as well. But you're going to have this decrescendo crescendo pattern because, again, the pressure differential when you finally open up that tricuspid valve is going to be the greatest at the beginning or at the opening. So you're going to have the most turbulent flow at the very beginning when that valve opens. And then as flow goes, that turbulence starts to decline, that pressure gradient between the ventricle and the right atria starts to shrink, so that turbulent flow starts to slow down, and then you have that atrial kick, and now you have that pressure increase again. So that increases that turbulent flow. So that's why you have that decrescendo crescendo pattern with this murmur. Okay. EKG, the right ventricle is going to look normal. It's a right atrial enlargement that you're going to see on that EKG because that right atria is going to have to accommodate for that higher pressure, higher volume that it's experiencing from this condition. Okay, so right atrial, an isolated right atrial enlargement is the finding on your EKG for this. Chest X-ray, you're going to see that isolated right atrial enlargement, possibly. Echo is going to be your test of choice because you're going to be able to see the diseased valve, and you're going to be able to determine the secondary impacts, the physiologic changes that occur because of this condition with your echocardiogram. So how are you going to treat it? Well, this is a pressure problem, but ultimately then also becomes a volume problem. So you've got to manage that volume overload. So things that you can do to manage that volume overload are salt restrictions, diuretics, to take off some of that load. But ultimately, if they are having symptoms related to this tricuspid stenosis, they're going to need surgery. Okay, and the surgery that you can do is similar to this, the surgery that we do for the mitral valve, where you do that balloon valvotomy. You place the balloon, deflated balloon, through the valve, and then you inflate the balloon, and then you kind of open up that that valve with the balloon. Okay, so that's the most common treatment that we use today. If they are not a candidate for the mitral or the tricuspid valve balloon valvotomy, then they can do a valve replacement surgery. But again, that's higher risk, higher morbidity, mortality just from the operation itself. That was tricuspid stenosis. Let's look at tricuspid regurgitation. So what's interesting is the most common causes of tricuspid regurgitation in the United States is actually secondary causes. Okay, so remember we said secondary causes are things outside of the valve and the components of the valve leading to this, leading to the dysfunction of the valve itself. So one of the key things, or one of the most common things that leads to this tricuspid regurgitation is when you start having left ventricular heart failure, which we're going to talk about in our next lecture on Monday, that will translate back up to the lungs, which then translates back to the right side of the heart, and that causes a dilation of the right ventricle. And in the process of having that dilation occur, it pulls those valve leaflets apart, so they cannot close and seal properly. Okay. So what are we going to see pathophysiologically from this? Ultimately, both are going to lead to heart failure, right-sided heart failure. But in the acute setting, you're going to have this pressure increase in the right ventricle, whereas in chronic, you don't really have that pressure change. It's a volume problem, and you get a dilation from that, but you don't get necessarily that pressure increase associated with it. So that's kind of the unique differences between an acute tricuspid regurgitation presentation and a chronic tricuspid regurgitation presentation. Going back to our lovely jugular venous pulsation wave, you're going to have prominent V waves. And remember, the V wave is when the tricuspid is, or sorry, the atria, the right atria is squeezing against that closed tricuspid valve. Okay. You're going to see that increase because when that tricuspid valve not having that integrity, you're going to have all that increased volume and all that increased pressure coming back to the atria. So now I have a much higher pressure and a much higher volume in the right atria than what should be there normally. So you get that prominent V wave present. Okay. On physical, what are you going to see with tricuspid regurgitation? You're going to be looking at the left lower sternal border, so the tricuspid auscultation site. This is a systolic murmur, right? Because the tricuspid valve should be closed during systole. It tends to also be a holosystolic, because remember, S1 is the closure of your tricuspid mitral valves. So if I don't have that valvular integrity of the tricuspid valve, does it make sense that that regurgitation murmur is going to present and develop immediately when that valve should be closed, and now you're having flow of blood going across the valve itself? Okay. EKG, you're going to see right atrial enlargement and right ventricular hypertrophy with this, because now there is a problem that's affecting the right ventricle. So this kind of helps you differentiate this from tricuspid stenosis, having that right ventricular hypertrophy being present on EKG. Echo is going to be your test of choice because you're going to be able to measure how much flow is regurgitating, and also be able to see the secondary impacts of that regurgitation volume. But the treatment for this is going to be, depending on if this is a primary problem, so the valve itself is the problem, or is there a secondary cause to this? And if there is a secondary cause, which we said secondary causes are the most common causes of this condition, then we need to manage those things. So for instance, if you have right-sided heart failure from left-sided heart failure, does it make sense that I need to treat that heart failure to help improve this tricuspid regurgitation? So we're going to talk about management of heart failure on Monday, and you'll see kind of the normal things we do for heart failure treatment. But they may qualify for surgery, and then if they do surgery, then they'll go in and we'll do a valve replacement. Okay. That's tricuspid valve. Okay. So now we finished 3 valves. We have 1 more. So pulmonic valvular disease is infrequently encountered. So we won't spend a lot of time talking about the pulmonic valve because it's the least common valve impacted. Remember, when we talked about rheumatic heart disease, we said mitral is most common, aortic second most common, and tricuspid is third most common, right? And that was rare that you saw tricuspid disease. We didn't ever say pulmonic, okay? So pulmonic disease, or pulmonic valvular disease is not impacted by rheumatic heart disease. But what can affect the pulmonic valve? Think about congenital things, okay? So tetralogy of flow, we talked about that, right, in the congenital heart disease lecture. One of the criteria, or one of the things that happens in the tetra is pulmonic stenosis, or at least a pulmonic outflow obstruction, right? So tetralogy of flow. Noonan syndrome is an interesting thing. So this is a syndrome that has a bunch of different things. And you can see in the picture here, the typical visual findings that you're going to see in somebody who is affected by Noonan syndrome. But part of that syndrome is pulmonic stenosis. So that's just a component of this genetic disorder, is having pulmonic stenosis. And then there's a rare cause, this carcinoid syndrome, which is a GI neuroendocrine serotonin secreting like tumor that can then lead to, that because of that serotonin that's being produced, it then leads to a pulmonic stenosis. Okay. So what's the pathophysiologic changes you're going to see with this? Well, with pulmonic stenosis, I'm having to exert a higher pressure in the right ventricle in order to open the pulmonic valve. So you're going to see that right ventricular hypertrophy. And if it can't keep up with the volume of that venous return, then it's going to lead to right-sided heart failure. Okay. Symptoms with it, they could be completely asymptomatic, but then as it gets worse, this becomes a cardiac output problem because you're not getting that blood, that deoxygenated blood, to the lungs to become oxygenated to get over to the left side. So ultimately you're impacting the function of the left side because you're not giving it the oxygenated blood necessary to keep up with exertion. So they're going to have exertional symptoms, but they also are going to have symptoms of right-sided heart failure as well, i.e. JVD and peripheral edema, gut edema, and those things. The physical exam finding for pulmonic stenosis is similar to aortic stenosis, where you have this crescendo, decrescendo, or diamond pattern to it. Because again, that squeeze, as that ventricle starts to squeeze, you finally generate a pressure to induce the valve to open and get that flow, but then you start to continue squeezing, continues to squeeze, continues to increase pressure, increases that turbulent blood flow, gets louder, and then you get that peak where now you start to relax, that pressure starts to drop, and then it slows down that turbulent blood flow, and then the murmur intensity gets softer and gives you that decrescendo pattern. And this is best heard in the pulmonic auscultation site, so the left upper sternal border. Your ancillary studies, EKG is going to show right ventricular hypertrophy. Your test of choice is going to be, of course, echo. Seems like that's a pattern for everything in cardiology. Is echo is always your test of choice, right? The treatment for it is we can either do a balloon valvuloplasty, where I can put the balloon in and kind of inflate the balloon and pop that valve open, or I can go in and do a valve replacement as well. All right, so let's finish up this lecture talking about pulmonic regurgitation. Again, acute versus chronic, pathophysiologic changes, and primary versus secondary causes of this condition. Ultimately, the most common cause of pulmonic regurgitation is pulmonary hypertension. So if I have elevated pulmonary pressures, that is going to translate and impact the function of that pulmonic valve so that it will induce a regurgitation. Okay? Ultimately, because of that regurgitation from that higher pressure in the pulmonary system, it's going to lead to increased pressures, increased volumes in the right ventricle, which then is going to translate to the right atria, which then leads to the peripheral venous system, and they're going to have that right heart failure symptoms present from this. Okay. They may be asymptomatic because it kind of depends on the severity of that pulmonic regurgitation, but as the condition gets worse, more regurgitant volume comes back to the right ventricle. You start to see the secondary impacts on the pathophysiology of it. They are going to become symptomatic with like your right-sided heart failure symptoms, but again, you're also having that forward flow problem, so you're going to have those exertional symptoms as well. On physical, the classic finding is this decrescendo pattern, best heard at Erb's point in diastole. Okay? And again, similar to the aortic regurgitation murmur, it's decrescendo because that and it's diastolic because that S2 is the closure of your pulmonic valve, or at least it should be the closure of your pulmonic valve. But because you don't get that good seal, you start to get that reflux, and that pressure differential is going to be the highest there at the beginning. And then as more volume comes back from the pulmonary system into the right ventricle, that pressure in the right ventricle is going to increase. That's going to diminish your pressure differential between the pulmonary system and the right ventricle. That turbulent flow is going to slow down, which is going to decrease the intensity of the sound or the murmur, which gives you that decrescendo pattern. Okay. Your ancillary studies, okay, you may see right ventricular hypertrophy on your EKG. You may see that also on your chest x-ray. You may see some pulmonary changes because, hey, if you have pulmonary hypertension that's causing pulmonary regurg, then it's probably going to be something you'll see those things present on your chest x-ray. Echocardiogram, again, is a test of choice, kind of be able to visualize it, measure the amount of volume that's coming back. And the treatment for this is, if they're asymptomatic, just kind of watch them. If they have pulmonary hypertension that's causing this disease, then treat the pulmonary hypertension to encourage that forward flow of the valve, or of the blood volume. But if it's the valve itself that is the problem, so you have a primary cause, then you're thinking about doing surgery to fix the valve itself. Okay. Questions about this lecture? All right, that's the end of this. As you can see, we are making progress